Today's topic will be on sympathomimetic or sympathetic drugs. So we've already know what is the basics of it. Now, how does this catecholamine? The sympathetic system, we know it's not adrenaline, and also dopamine is also included here. See, what happens is tyrosine, with the help of tyrosine hydroxylase, this is the rate limiting enzyme, will form dopa, and then dopa decarboxylase will help in forming dopamine. And then what happens is dopamine is converted to norepinephrine and epinephrine. Now this norepinephrine is going to come to the is in a vesicle, and once it reaches the end plate, it is being released into the synapse, and then a response is produced. Now we know in adrenergic system, what are the receptors? We have adrenergic receptors. The adrenergic receptors are alpha and beta receptors. So this is what alpha and beta receptors. Now this one mechanism is by it acts on the postsynaptic alpha and beta receptors. Another mechanism is it acts on the presynaptic receptor itself, and I'll show you. See. So yeah, and before that, how does this tyrosine come inside this? With the help of sodium channel. Once sodium inside, tyrosine also will come inside. So tyrosine, levodopa, dopa, dopamine, norepinephrine, and this norepinephrine, once the calcium is influxed into the presynaptic membrane, it is going to get released and respond in the postsynaptic. I told you the presynaptic receptor, which will further inhibit the release of norepinephrine. This is like a feedback mechanism, and this at the synapse it has to be dissolved with the help of COMT enzyme and norepinephrine reuptake channel, which then goes into the presynaptic. The norepinephrine will go back to the presynaptic membrane, and then monoamino oxidase will degrade it so that it can go to another cycle and formation of norepinephrine. So this is what happens in sympathetic system. Now, we talked about the receptors. I'll tell about it once again. Okay, so yeah. So we know in sympathetic system, the preganglionic will release ACH, and the nicotinic receptors will act on it. So it can be either NN or NM, that is N muscarinic and N neuronal, and then after that norepinephrine is released in the postganglionic adrenergic neuron, and then it acts on alpha and beta in the organs. But in the kidney, what happens is the long sympathetic neuron will release ACH into the nicotinic receptors, and the adrenal gland will release 80% of epinephrine and 20% of norepinephrine, and then it will go and act on alpha and beta receptors. Okay, cool. Now we'll talk about the receptors. So we have two types of receptors, alpha and beta. Now this alpha, it is a where we know alpha is a metabotropic receptor. Both alpha and beta are metabotropic receptors. Now alpha is a GQ receptor, so it's a stimulatory type. It will increase IP3, inositol phosphate, and diacylglycerol, which in turn will increase calcium. So there will be a lot of vasoconstriction. We know what does sympathetic system do. We know what is sympathetic. It will cause vasoconstriction. It will cause mydriasis in the eye. It will cause urinary retention and contraction of the sphincters. And in the liver, it will cause glycogenolysis because blood glucose will be released. And in the kidney, it will inhibit the release of renin. Renin is used in regulation of the BP. So that is what happens in alpha 1 receptors. In alpha 2 receptors, what happens is this is a GI type of metabotropic, the G protein coupled receptor. So this G protein coupled receptor will act on the presynaptic membrane, that is alpha 2. So it will decrease the CAMT. So in general, the epinephrine will be decreased. And also in pancreas, it will decrease the release of insulin, so that the blood glucose levels will be more. So generally in sympathetic system, the blood glucose level will be more. Sympathetic stimulation, the blood glucose. That is why while running, so if you see as a whole, while running you need vasoconstriction, you need mydriasis, you don't have to pee during running, you need the blood glucose levels, right? So all the metabolism will be faster. So all these things will be acting on alpha 1 and alpha 2 receptors. So yeah, so this is what is seen here. About the drugs, we'll talk about the drugs later. Next is the beta receptor. Now the beta receptor, there are three types of beta receptors. So beta 1, beta 2 and beta 3. So beta 1, it will, again I'll show you this. See, beta 1 will increase the heart rate. So it's beta 1 is primarily present in the heart. Increase the heart rate, increase the contractility, increase the AV conduction. It will also increase the renin and BP release. So that is there. Now, beta 2, what happens is present mostly in the bronchus, so used in bronchodilation, vasodilation, and also in pancreas. It will increase the release of insulin. Therefore, it will increase the release of insulin. Beta 2, it will not decrease the insulin. Decrease is done by alpha 2. Beta 2 will increase the release of insulin, will inhibit the GI motility by causing relaxation of the GIT, will inhibit labor also. Beta 3 will cause lipolysis, so there will be more of lipolysis in beta 3, and it can also cause urinary retention. This is what happens in alpha and beta. Okay, so next we will see what are the adrenergic agonists. What are the types of agonists? We'll see all that. Okay, before that, these are further divided into catecholamines and non-catecholamines. Now, what is the use of saying whether it's catecholamine or non-catecholamine is, see, catecholamines are like the norepinephrine, epinephrine and dopamine. They are ineffective in oral. If given orally, they are given ineffective. That's why it's mostly IV and have short duration of action, and they do not cross the CNS. But non-catecholamines, the non-catecholamines are like our phenylephrine, oxymetazoline, and all those drugs. They are effective and they are long acting and they have good CNS penetration. That is why the non-catecholamines are much more better than compared to catecholamines. Now, okay, so again, these are adrenergic agonists. They can again be classified into direct adrenergic agonists, which is the dopamine, noradrenaline, adrenaline. These are all endogenous direct. Exogenous direct are phenyldopamin, dobutamine and isoprenaline, and these are non-selective direct agonists. And we also have indirect acting. See, we have direct acting agonists, we have indirect acting agonists, and we have the mixed acting agonists. Okay, so we'll see what are the direct acting agonists. So the direct acting agonists are non-selectives. We have epinephrine, and we have norepinephrine, and we have dopamine. Okay, so first epinephrine. See, epinephrine or adrenaline will act on all receptors, alpha 1, alpha 2, beta 1, beta 2. Now, beta 1 is responsible for the systolic BP. Alpha 1 and beta 2 are together responsible for diastolic BP, and the baroreceptor reflex is responsible for the heart rate. Now, what happens is beta 1 adrenaline will increase the systolic BP, and since it acts on both alpha 1 and beta 2, there will be no change in the diastolic BP, and and then the heart rate will be more. Now, adrenaline is used, it will increase the vasoconstriction, it will increase the vasoconstriction, it will increase the BP, and it will increase the cardiac output, and it helps in bronchodilation. That is why it's used in anaphylactic shock. Anaphylactic shock, 1:1000 ml, 0.5 ml IM is given. This is the concentration. Cardiac arrest, in hypotensive cardiac arrest, what do? We given 1:10,000, 0.1 ml IV will be, 1:10,000, 10 ml IV is given. Severe asthma, 0.5 ml is given, and it is the same ratio, 1:1000, subcutaneously it is given. With local anesthetics is given as 1:2 lakhs as subcutaneous. and 1 is to 100 is given as an inhalation. So this is case of adrenaline. Now noradrenaline, it doesn't act on all receptors. Noradrenaline will act on only alpha 1, alpha 2 and beta 1. Now see, it doesn't act on beta 2. What does beta 2 do is, it will cause vasodilation and vascular smooth muscles and skeletal smooth muscles. Since there is no action on beta 2, there will be primarily more of vasoconstriction. So beta 2 is also present on the lungs, so it doesn't cause bronchodilation. So what does noradrenaline do? It will increase the systolic BP because it acts on beta 1. Now beta 2 doesn't act, so it only acts primarily alpha 1, uncontrolled alpha 1 will be there, so it will increase the BP. Now what happens when the diastolic, see what is the reflex, I'll tell you. See, when the diastolic blood pressure is more, the baroreceptor will sense it, and then that vagus nerve will, action potential will be generated, and the vagus nerve will take it to the heart, and then it will decrease the release of ACTH, so that okay, I think so. This is okay. I think baroreceptor reflex, I'm not sure. I'll read it and say the next thing. So yeah, however, something happened. The PNS will be activated. So the vagus nerve will activate. So they'll decrease. I don't know which transmitter is decreased. So if it decreases that neurotransmitter, what happens is heart rate will decrease. So if diastolic blood pressure is more, heart rate will decrease. If diastolic blood pressure is less, heart rate will be more. So this is what happens here. And in case of, this is adrenaline and noradrenaline, and so noradrenaline is used as a drug of choice for hypotensive shock and CHF. See, best vasopressor is noradrenaline. So if you have a patient with cardiac shock with BP very less than 90, first you think of noradrenaline. There's no if the BP inotropic, see, when BP is more, it's better to give the vasopressor than to give an inotropic. Without any signs of, if BP is more than 90, you can give you can compensate by giving just the inotropic drug, and the best inotrope is dobutamine. Okay, so that is regarding norepinephrine. Another drug is dopamine. Now dopamine will act on it is at low dose, that is at okay, when it's less than 2 microgram per kg, it will act only in the renal system. So it will cause blood vessels vasodilation. So it will increase the urine output, it will increase the cardiac output, and therefore increasing the BP. On beta 1, if it's